Welcome all to my YouTube channel Medicine Made Easy. Today we will discuss about one of the rare electrolyte abnormality, but very important electrolyte abnormality in the form of hypernatremia. Myself Dr. Mahesh Patel. I am practicing physician. So in this video the contents will be like definition of hypernatremia, etiology, what are the clinical features, and what is the management of hypernatremia. So by definition, serum sodium more than 145 milliequivalent per liter is called as hypernatremia. It is most often encountered in critically ill patients when large amounts of hypertonic fluids are administered. When patient is admitted in ICU for a long time, large amounts of fluids are administered and it can lead to hypernatremia. It is usually due to water deficit and not due to increased sodium or not due to sodium overload. We might think it is sodium overload, but it is water deficit. These are the etiologies. First is the loss of water when in febrile conditions or in hypercatabolic conditions like thyrotoxicosis, sepsis and severe burns. There is loss of water. Second is loss of hypotonic fluids via the skin in the form of excessive sweating or GI loss, even vomiting, diarrhea, or diseases of the kidneys or central diabetes insipidus or nephrogenic diabetes insipidus, and osmotic diuresis caused by hyperglycemia, urea and mannitol. It can be due to insufficient water intake in unconscious patients or in infants who cannot take orally much fluids. It can lead to hypernatremia. And it is also can be due to iatrogenic due to excessive sodium correction in the form of administration of soda bicarbonate in acidotic conditions like metabolic acidosis, and also while administration of hypertonic saline infusion while correcting hyponatremia or cerebral edema. So clinical features: early mild hypernatremia can cause symptoms like nausea, vomiting, loss of appetite, weakness, muscle cramps. But in severe form or when acute, sudden hypernatremia can cause serious manifestations like impaired mental status in the form of agitation or somnolence, or it may progress to coma and even death. It carries a very high mortality, hypernatremia. Management is basically of finding out the underlying cause of hypernatremia. It should be corrected, like drugs or any hyperglycemia, hypercalcemia, hypokalemia or diarrhea. It is due to water deficit towards the water deficit should be calculated, and it is replaced over 48 hours slowly, and rapid correction is avoided. Water deficit is calculated by the formula plasma sodium minus 140 divided by 140 into 0.6 into body weight in kg. So whatever calculated water deficit is corrected in 48 hours slowly. And safe rate of correction is reduction of serum sodium by 1 milliequivalent every 2 hours or 10 milliequivalent per liter for first 24 hours. Not more than 10 milliequivalent should be corrected in a day. Goal of treatment is to reduce serum sodium to 145 milliequivalent per liter. Treatment of hypernatremia is in the form of water, either orally or if a patient is unconscious, by putting the IH tube we can give water. And acute hypernatremia can be treated vigorously with 5% dextrose infusion. Hypernatremia can be with extracellular volume contraction, which is initially treated with isotonic saline. Then it is subsequently water deficit can be replaced with water by mouth or IV, 5% dextrose or 0.45% NaCl infusion. Hypernatremia with increased extracellular fluid volume is treated with loop diuretic along with water to facilitate sodium excretion. What will be the change in serum sodium after administration of IV fluid can be calculated by formula of infused sodium divided by per liter minus serum sodium divided by total body water in liters plus 1. Total body water is calculated by 0.5 into total body weight in kg. In this way we can find out how the sodium will get corrected, how much it will get corrected approximately by administration of 1 liter of that IV fluid. Thank you.